buenos días y muchas gracias por acompañarnos. Siendo ya las 8:30 de la mañana, para mí es un honor dar la bienvenida a la doctora Sabine Kahneman, endocrinóloga pediatra del Center of Atypical Sex and Gender Development of Amsterdam. La doctora Kahneman, le agradecemos sinceramente que se haya conectado tan temprano y que comparta con nosotros su tiempo y su experiencia. También agradecemos a todas las personas que están hoy aquí, su interés por comprender y profundizar en el tratamiento hormonal en adolescentes transgénero. Un tema que aún se aborda poco, pero que es fundamental para garantizar una atención basada en evidencia, respeto y bienestar. Todo esto es muy valioso para nosotros. Su voluntad de aprender y de aumentar el conocimiento en este ámbito demuestra un compromiso real con la salud y los derechos de los jóvenes trans y no binarios. Sé que tendremos una presentación clara y enriquecedora que nos permitirá actualizar conocimientos, resolver dudas y mejorar nuestras prácticas. Les invitamos a anotar sus preguntas en el chat o al final si queremos dialogar directamente con la doctora Sabine. La doctora Sabine Kahneman es una endocrinóloga pediátrica. Ella está en el Center for Atypical Sex and Gender Development of Amsterdam desde el 2020. Es miembro de la Junta del Center of Expertise on Gender Dysphoria. Anteriormente era responsable de la clínica de género en endocrinología en Leiden University Medical Center y trabajó en el equipo de variaciones del desarrollo sexual en Erasmus University Medical Center de Rotterdam. Obtuvo su doctorado en la Universidad de Cambridge en el Reino Unido. Sus principales áreas de interés son las variaciones del desarrollo sexual y la atención a personas transgénero. Es coautora de la Guía Práctica Clínica de la Endocrine Society, Endocrine Treatment for Gender Dysphoric, Gender Incongruent Persons, y de la norma de calidad neerlandesa para la atención a personas transgénero. Entonces es para mí un gusto poder estar aquí con ustedes y presentarles a la doctora Sabine Kahneman. Hi, Sabine.
Buenos días a todos.
So perfect. The floor is for you.
Thank you for the invitation and for being able to speak to you from the other side of the world. I will share my presentation and discuss the care for transgender adolescents, and I'll go over 2 cases. Well, if anything is unclear, then please let me know. So I'm going to discuss 2 cases, as I just said, and the care will follow the guidelines that are available. So I've listed 3 here: the Endocrine Society guideline, the standards of care issued by the World Professional Association for Transgender Health, and a recent expert opinion paper. So most of the things you can find back in these guidelines. And the first case is Amy, and she is 13 years old. She was registered male sex at birth. Her medical history is unremarkable, and she's indicated
Hi,
feeling
Sabine.
like a girl. Yes.
Could you share your presentation?
Oh, did I not share it? Oh, apologies. I will quickly share
No
it so you
worries.
can actually see what I am discussing. Let me just go back. One moment.
Yeah.
Great. Apologies.
Yeah, no worries. Yeah,
Right.
perfect.
So, yes, as I just said, I will use the 3 guidelines that are available. You can find them here: the Endocrine Society guideline, WPATH standards of care, and the recent expert opinion paper that was issued by the European Society for Pediatric Endocrinology and Endo-ERN. And the first case is Amy, as I just started to say. So she's 13 years old, registered male at birth, with an unremarkable history, and has indicated that she feels like a girl from very early on, about age 3 to 4 years. And she had a social transition when she was 8. And she's now been referred to the clinic because she worries that puberty may start it, and she does not want her voice to break. And she would like to have female puberty. Her parents are supportive, and then at the examination, her tenor stage is G2, P3 with a testicular volume of 6 milliliters. So I have a few questions. You don't have to vote. You can just think about it for yourself. What would you do in this situation? Would you prescribe a junior age analog to stop puberty and then refer to a psychologist for further assessment? Or would you prescribe a junior age analog to stop puberty, but would you not make a referral to a psychologist because the gender dysphoria is very clear for this adolescent? Or would you first refer to a psychologist and not prescribe any medication yet? So I'll discuss what the way we work, and then maybe later on we can have a discussion if you agree or have different views. So in Amsterdam, we do always have an assessment by a multidisciplinary team before starting any medical treatment. And the assessment is not only about gender identity or gender identity development, but about the broader psychological development, cognitive development, psychosexual, social. We also see if there's any mental health problems or medical conditions, and the pubertal stage. And well, that I already indicated in the slide. Obviously, she is in puberty, but that would be important to know before considering any medical treatment, because before puberty, we don't offer any medical interventions. And then it's not just an assessment, there's also counselling before the start of any medical treatment. And I'll go over this in a bit more detail, but there's also a lot of things that we talk about to adolescents and their parents, like what are the options for medical treatment, the alternatives, and weigh all the benefits and risks and impacts and uncertainties together with them. So I'll go into that in a little bit more detail. So to go back to the question, we would refer to the psychologist within our team and not start any treatment yet. Once the assessment has been done and the treatment does seem like an option, we discuss that, of course, the adolescent, if transgender adolescents, they have options, so they can choose, they can pursue medical treatment, but they could also sometimes maybe find other ways to deal with their gender dysphoria, such as speech therapy or hair removal, wearing of binders, that kind of thing. And that may also be an option in parallel to medical treatment or while waiting for medical treatment. And then the medical treatment options for trans feminine adolescents would be junior age analog treatment to suppress testosterone and prevent pubertal progress. And then estradiol in the Netherlands is mostly started from age 15 to 16 years, but different countries have different approaches, and there may also be regulations, local regulations. And then surgery in the Netherlands is from 18 years, like genital surgery. It's good to realise when starting the treatment that the evidence so far suggests a really large proportions of adolescents that starts the medical treatment will continue. So here's some percentages from an increasing number of studies. You can see the reference up here. So 85 to 99% who starts the puberty suppression continues, and then of those starting gender-affirming hormone treatment, also the vast majority continues. One study from the United States found a lower percentage of 74%, but all other studies have found percentages above 90%. So I think it's good to realise that when you counsel adolescents. So what are the potential benefits? We asked the adolescents what are they expecting, what are they hoping to achieve with the treatment, and I think it's good to discuss with them so they also have realistic expectations. And Amy says she just wants to be completely female. She wants a feminine voice, breasts just like her friends and other women, a feminine figure with hips, and she also would like to have a feminine height, so she hopes she won't grow too much. So what do we know about these outcomes? Is this realistic? So we do know that junior age analog treatment suppresses testosterone and prevents further breaking of the voice and development of the Adam's apple and facial hair growth. If that has already occurred, it won't reverse. So that's of course important for people to know that it's if voice is broken, we cannot return it by hormone treatment. What do we know about the breast development? This is a study from a few years ago that looked at Tanner stage, and you can see after 3 years of this estrogen treatment, after 3 years, the median breast stage was Tanner 5, but there were also quite a few still at Tanner stage 2 or 3. And then more recently, we also looked at volume, breast volume, and you can see the majority had breast cup size A or smaller. So the distribution is a bit, the breast size is a bit smaller than in the general population. Then the body shape, Amy said she would like to have wider hips. So this is looking at the waist to hip ratio. So if you have wider hips, the waist to hip ratio is low. So you can see that cisgender women are lower than the cisgender men. And the trans women in adolescence, if you start puberty suppression, you prevent male puberty, and you can see that already results in a drop of waist to hip ratio. And then with estrogen treatment, the drop continues, and at a young adult age, it's fairly similar to cisgender women, the body figure. We recently also looked at the skeleton and how the shape changes with treatment, and found that the shoulder width, and so we assessed this on DEXA scans. You can see here the measurement we took, that was a bit smaller in those who started puberty suppression from early puberty, so Tanner stage G2 or 3. So it does make a little bit of a difference for body shape. Then adult height. Amy said she didn't want to grow very tall. We know that the adult height, this is a graph that looked at the difference between predicted adult height based on the height at the start of puberty suppression and the bone age at the start of puberty suppression. So you can then make an estimate, and we use the male prediction for this. So the growth you would expect if you would not interfere in any way with growth. And then looked at the adult height that people achieved after puberty suppression and estrogen treatment, and it was actually fairly similar to what we expected. So you can see the median was just below 0, but it was not, so it was not very different. So people, trans feminine adolescents, will be relatively tall compared to cisgender women because of the sex difference in height. So this is something to discuss. So then something about the side effects and potential risks that adolescents and their parents also often have questions about. So they want to know, what are the side effects? And the parents have heard that puberty suppression affects bone health. So they want to know a little bit more about that, and also what it means for fertility, whether she'll be able to have children in any way. So the short-term side effects of GnRH analogues are mostly mild headaches or fatigue. Sometimes some adolescents have a bit more severe complaints, but mostly mild. And mood swings, weight gain, and sleep problems have been reported, although not in a very large percentage. And then estradiol treatment results in breast tenderness, which also occurs during general puberty in general, and fatigue and emotional changes have also been reported, but there's not been a lot of studies that have really looked at this in detail and see how many people have had these complaints. Then the bone mineral density, which the parents asked about. So this is a graphs of the bone mineral density Z score. So 0 is average. And this looked at 4 time points. So the start of GnRH analog treatment, the start of gender affirming hormone treatment, then young adult age around 22, and the follow-up visit at age 28. And you can see at all 3 sites, the lumbar spine, total hip, and femoral neck, there's a drop in the Z score, which means that, compared to peers, the bone mineral density doesn't increase as much with the GnRH analog treatment. And at the hip and the femoral neck, you see there is catch-up. So it returns to the pre-treatment value, but at the lumbar spine, it remains quite low. So the question is this an effect of the treatment? Of course, there's in a lot of the studies we don't have untreated controls, so it's difficult to say. So to get an idea, what we did is look at all the baseline values of people that started at different ages. So that's this graph over here. So this is cross-sectional. So it's people that had their first scan at age 12 or 16 or 20 because they started treatment at different ages. And what you can see is that the older they were, the lower their Z scores were. So this is not longitudinal data, but it seems to suggest that that for some reason, people as they get older have lower BMD-Z scores compared to the general population. So some of this decline that we see over time might also have occurred if they had not been treated. And we think lifestyle factors may play a role in this. It was also related to muscle mass, so maybe like the amount of exercise is different from peers and plays a role in this. So we do also try to pay attention to the lifestyle counseling and advise adolescents on calcium intake, vitamin D, and exercise, intoxications, those kind of things. So then fertility, this is also a topic we discuss with every adolescent starting treatment. And Amy thinks she will want to have children in the future and would also like the option to have biological children. So here is another question for you to just consider. Should you discuss fertility preservation at this stage? So you could say maybe no, because the effect of GnRH analogues is reversible, so it's not really necessary to discuss at this stage. Or no, there's no established fertility preservations that are feasible at this moment, so then it might not be useful to discuss it. Or would you say yes, we should discuss it, but if she wants to pursue fertility preservation, she'll have to delay the treatment? So we do know that GnRH analog treatment from precocious puberty, that the suppression of spermatogenesis is reversible. Estrogen does suppress spermatogenesis in most adolescents, although in some gonadectomy samples there was evidence that there was still ongoing spermatogenesis. And if you stop estrogen, we cannot guarantee that spermatogenesis will resume. There's not a lot of data, but there's some people have stopped and have the spermatogenesis has restarted. So it may be reversible, but we don't really know. We don't have sufficient data yet. And if she wants to have a gonadectomy later on, then that will result in definite infertility. So at the stage when people are starting with the GnRH analog, there will still be the chance to stop later on and pursue fertility preservation, but that of course will also mean that puberty will resume, and we know that from the data I showed you before that most adolescents continue to use GnRH analog and then go on to use estrogen. So we do think it's important to discuss before people start with GnRH analogs. And then what are the options for fertility preservation for trans feminine adolescents? It could either be semen cryopreservation, but for this, the adolescent would need to be able to have ejaculation, or a testicular sperm extraction. And for this, for both options, puberty has to have progressed sufficiently for spermatogenesis to be there. So for TC, we find that that's possible from approximately testicular volume of approximately 10 milliliters by orchidometer. And then some clinics offer testicular tissue cryopreservation, so spermatogonial stem cells, but that's not offered in Amsterdam. So this for Amy, who's now at tenor stage G2 and testicular volume of 6 milliliters, if she wants to pursue fertility preservation, she would have to wait for puberty to progress. So this also has some impact on later options for vaginoplasty. If you start puberty suppression very early on, so at tenor stage G2 or G3, then the penis will not grow as much as when you start later on at tenor stage G4 or 5, or when you start treatment in adulthood. And for the vaginoplasty, the penile tissue, the penile skin can be used for the penis inversion technique, and this is not always possible if you start in early puberty because the tissue may be insufficient. So in this study, a larger percentage had an intestinal vaginoplasty in the group that started puberty suppression in early puberty. But there is also other options using tissue grafts from elsewhere. But this adolescents could take this into account in their decision. So Amy decides she wants to pursue testicular sperm extraction, and she waits another year before this is successfully completed. And at that point, her testosterone has increased to 11 nanomoles per liter, and her voice has started to drop a little bit, but it's still within the female range. So, and this is always that is different. This is not the same for every adolescent. So, the time the voice starts to drop is around the same time that the spermatogenesis is sufficient for TC. And then after the fertility preservation, she starts to generate analog treatment, and then there is follow-up both by the pediatric endocrinologist, but also by the mental health professional. So I don't know, shall we take questions at this point, Elma, or should I go on and discuss the other adolescent first?
¿Alguien del público quisiera o tuviera alguna pregunta al momento o quisieran que continuáramos con la presentación porque va a haber un segundo caso? So just asking if there are some questions.
Final, ¿no?
Okay, so they're telling just at the end. Thank you, Sabine.
Okay,
not
then
the-
I will continue. That's fine.
Yeah, if not, they can write it down on the chat.
Yep, great. Okay, so then the second adolescent I want to discuss is a transmasculine adolescent. This is Julian, who's 13 years old. He was registered female sex at birth and has always been a tomboy. He had a diagnosis of ADHD at age 8, and when puberty started, when he was 10, he became a bit more withdrawn, but it wasn't clear to parents then that he felt like a boy, but he discussed this with his parents when he was 12. And then he made a social transition quite soon after when he started secondary school. And the reason he's referred at this point is that he recently had menarche and is very distressed about the bleeding, wants this to stop. Oh, sorry. And he would like to undergo male puberty. And again, parents are supportive, and the mental health professional has already diagnosed gender dysphoria and done counseling and thinks hormonal treatment is indicated. So then another question, what kind of hormonal treatment would you prescribe? I guess this also depends on what's available and perhaps also on the preference of the adolescents and the parents. But these are a few options: continuous oral contraceptive, a generate analog or progestin, or testosterone treatment. So again, we discuss all the options. There is again the non-medical options, for example, use of the binder, which quite a few adolescents do find helpful. And then for the medical treatment to suppress hormones, so if you really want to have hormone suppression, you could use either generate analog or progestin. With the oral contraceptive, you can stop menstrual bleeding, but it does obviously contain estrogen, so it's not really hormone suppression. If adolescents want contraception, then obviously that could be a relevant option. But some don't want to use the oral contraceptive because of the estrogen and because sometimes they experience increase in breast size. Testosterone treatment does, after a while, result in amenorrhea in most adolescents, but in the Netherlands, we don't prescribe this before age 15 to 16 years. So in a 13-year-old, we would not yet prescribe testosterone. And then this is just about the treatment in general. Surgery in the Netherlands is also possible from 18, apart from the mastectomy, which is possible from age 16. So for the menstrual suppression, as I already said, the generate analogs suppress estradiol and the menstruation stops. So it is very effective, and it also prevents further breast development. So this is a study that looked at the cup size at the time that people chose to undergo in young adulthood, and also looked if they chose to undergo a mastectomy. So of the group that started GnRH analog treatment in early puberty, so tender breast stage 2 or 3, the vast majority had cup A or AA, and about half did not need a mastectomy at all. And if you start in late puberty, you see the cup size generally is a little bit larger, and most or nearly all did have a mastectomy. And when hormone treatment was started in adulthood, everyone had a mastectomy, and here you see that the half needed the inframemory approach, whereas in those that had puberty suppression, the periareolar approach was more often possible, which is related to the breast size. So even if you start in late puberty, there is some reduction in breast size compared to starting treatment in adulthood. Progestin also suppresses estradiol. So this is a graph of estrogen levels during linestrol treatment. And you can see that it does go down. The gray area is the female reference range, and the hatched area is the male reference range. And you can see that the estrogen goes down into the male reference range. We don't really have any data on breast development, but because the estrogen goes down, you could imagine that it also limits breast development a little bit, but there's no real data. And it does also result in suppression of menstrual bleeding, but there is more breakthrough bleeding compared to GnRH analog treatment, especially in the first 6 months. There can be spotting, and that becomes a bit more uncommon after the longer you use it. Then what can people expect for, with regard to body shape? So this is again looking at waist to hip ratio. And during the GnRH analog treatment in the trans boys, we don't see it doesn't go towards the male reference range. It follows the female reference range, but with testosterone treatment, then it goes up. So then you really see the change in body shape, and the hips become sort of more narrow compared to the waist. This is with linestrol, so with the progestin, it's been reported that this does result in an increase in waist to hip ratio. So the linestrol results in a bit more male body shape, whereas the GnRH analog treatment does not. Then we also have some data on body composition, so muscle mass and fat mass. And here you can, at the top, you can see the absolute mass, and here's the Z scores. So for Julian, who's in late puberty, so tender stage B4 or 5, you can see that the lean mass Z scores actually drop a little bit, and the fat mass Z scores go up a little bit. So your fat percentage increases with the GnRH analog treatment. And again, this is a bit different with the linestrol, the progestin, where there was a bit of an increase of the lean mass, and the fat mass did not change. So this may be something that adolescents want to consider in their choice of the option of treatment. And then with testosterone, if you do choose a GnRH analog, the lean mass will go up with testosterone. So here you can see the Z scores increase, and the fat mass goes down once testosterone treatment is started. So what about the bone in the transmasculine adolescents? So here you can see they actually have better scores to start with. They're around 0, which is different from the feminine adolescents. Again, you see a drop with the GnRH analog at all the sites, but a complete catch-up with testosterone. So there doesn't seem to be any lasting effect of the GnRH analog treatment. So again, we get a lot of questions about growth. Julian is now 166, and in the Netherlands, 170 is about -2 SD. Dutch are quite tall, and Julian would really like to grow as much as possible. And we did an X-ray, and his bone age was 12.6 years. So he asked if the GnRH analog treatment sounds quite good, but if I start now and I would start testosterone treatment in a few years, will this interrupt my growth spurt, and will I actually be shorter in the end? Because he would not like to lose any of his adult height. So we looked at this. This is a bit different representation compared to the other graph I showed you, but here, this is the mid-parental height, so the height you'd expect based on parents' height. This is the predicted adult height at the start of puberty suppression, so again, based on the height and the bone age at the moment that people started treatment. And the pinkish box is the actual adult height that people achieved. So they were similar to expected, and maybe a little bit taller. And we also looked at, it didn't matter at what moment people started. So this is the difference between adult height and predicted adult height versus the bone age at start of puberty suppression. And you can see there's quite a bit of variation, but there seems to be a trend that the younger adolescents, so those starting at a younger bone age tend to end up a bit taller than expected, and the closer you get to the well, if they're nearly finished with their growth, then it doesn't really make a big difference to the adult height. But overall, at least the adolescents don't seem to get shorter from the treatment, so we can reassure Julian that it will not have a negative effect on his adult height if he were to start treatment now. And fertility, again, we discussed, so the GnRH analog and the progestin give a reversible suppression of the menstrual cycle. Testosterone also suppresses the menstrual cycle, but we know, again, from gonadectomy samples that ovulation can still occur. So we also discussed this, that the adolescents also need to be aware that they could still ovulate and need to use contraception if that's relevant to them. The data now show that people have stopped testosterone, interrupted testosterone treatment to become pregnant or to pursue fertility preservation, and that does seem possible. So the oocytes are not, they are still there even though people use testosterone. So at the moment, we think that it's not that oocytes are not damaged by the testosterone in a way that adolescents should definitely pursue fertility preservation before they start the treatment. There still seem to be options after they've started testosterone treatment. But this is an area where I think there's a lot of research still going on, so we'll have more data about this in the following years. And then again, if they were to pursue a gonadectomy, then that will result in infertility. So the options are oocyte cryopreservation, but this is of course quite a demanding procedure with hormonal treatment and oocyte pickup. And the other option that's offered by some clinics is ovarian tissue cryopreservation. We don't offer this. I don't know if it's available in Mexico. So Julian decides that he does not want to pursue fertility preservation, and after all the counselling, he opts for the treatment with a progestin. And initially, he does have some bleeding still, but it's quite mild, and he thinks it's okay. And in the end, he does have amenorrhea. And now he's 15 years old. We make a jump in the time, and he wants to start testosterone treatment. And he wants to look a bit like this, with a beard and a moustache and a low voice. So again, we discuss what can he expect. First of all, what kind of treatment do we offer? This is from the SBERN document. So it's got quite a detailed table with the various options for short-acting intramuscular or long-acting intramuscular injections or transdermal gel, with some advice on the dose. And there's also some advice on the follow-up. So it's recommended to have follow-up by both the mental health professional and the pediatric endocrinologist to evaluate if adolescents are happy with the treatment, if it fulfills their expectations, whether they have side effects or doubts or questions. And then we do stop the progestin once an adult maintenance dose of the testosterone is reached, because usually that's enough for amenorrhea. This is from the Endocrine Society guideline, the advice on what lab testing to do. So hemoglobin and hematocrit, which are expected to increase, but just to check that it's not above the male reference range. And then lipids, where we do see that the LDL cholesterol goes up with the testosterone treatment, HDL cholesterol goes down in most studies, and we check the testosterone levels, particularly with the gel, to adjust the dose. And vitamin D, we check in all the adolescents because we see that vitamin D deficiency is really common. I guess you could also advise supplementation. Maybe it's less common in Mexico because it's much sunnier than in the Netherlands. So then Julian, after all the information, starts testosterone gel at age 15, and then a few years later, when he turns 18, there is a discussion about how his care continues. I don't know what it's like in Mexico. In Netherlands, most pediatric clinics provide care up until age 18, and around 18 you are referred to an adult endocrinologist. And I think it is really important to ensure that this process does happen, because long-term follow-up is recommended for the hormonal treatment. And it's a phase where young adults may be thinking about gender-affirming surgery. So it's important they know who to discuss this with and where they could, who could provide their treatment. And besides the medical treatment, I think there's a whole load of topics that are quite important, can be challenging, that people might want support with, like education, employment, relationships, family building, sexual function, those kind of topics. Yeah, I think it's important that they know who they can ask about all these things. So it's good to prepare them so they know what to expect and where they are going and who their new doctor will be. And there's various models. So if it's within the same hospital, you could have like a joint clinic perhaps, but some hospitals may not offer adult care and pediatric care. So then at least I think it's important that you know the other doctors and that they can reach you for information, and that you ensure that they have their first appointment there. So I've discussed quite a lot of the studies that we have and the evidence, but there are also things that we don't have data on, or very limited data. And the evidence that we have comes mostly from observational studies and mostly short term. So I think there is a lot that we still want to know, and that we are trying to get data on, but also some of the questions will not be solved by more data. And I think there will always be ethical dilemmas that that will occur. And there have been some papers how to deal with this as a team also, if you're really thinking, should we do this or this, and what is the best option, because both have advantages but also disadvantages. And this is a paper on moral case deliberation, where you discuss a particular situation and systematically see, okay, what from all the points of view from the team, but also the adolescents, the parents, maybe society, all the different angles, what values are important, and how to apply that to the particular situation. So that can be helpful. So another question that sometimes occurs is an adolescent, are they able to make a decision about such about a treatment that may have lifelong consequences, and how do you assess this? So this is a tool to look at decision-making competence in adolescents. So maybe that's also helpful. So in summary, the medical care, I think, should be offered by ideally by a multidisciplinary team with mental health professionals and endocrinology and fertility specialists, and perhaps surgical specialties if adolescents want to pursue surgical treatment. And prior to the hormonal treatment, a mental health and clinical evaluation is recommended, in addition to counseling about medical treatment options and alternatives, and all the benefits and side effects or risks associated with all the options, and the potential impact of the treatment on fertility, and options for fertility preservation should be discussed prior to the start of hormone treatment. And we do repeat the counseling later on as well, because some adolescents obviously are quite young when they are at this point where we discuss this. And I think it's good to come back to that when they're a bit older, because maybe their ideas will change and you can rediscuss the topic, obviously. And then an increasing body of outcome data is available, but as I just said, long-term data are really limited. So I think ideally the care would be combined with collection for data for research purposes. So it would be great if, that would also be possible in your clinics. So I just like to thank all the people that, all the adolescents that took part in the studies that I showed you, and all the PhD students and the huge gender team in Amsterdam. And I'll be happy to take any questions. Should I stop sharing their presentation? And then maybe if there's questions about particular slides, I can always go back to them.
Yeah, thanks a lot, Sabine. So yeah, we have some questions. First of all, lovely lecture. So two main questions that we have here in the chat are about legal and how can we address this matter for our adolescent transgender and non-binary. So at least they're asking here in Mexico, but also asking how is it in your country and even in Europe, I don't know. But I will answer the Mexico City part in Spanish. Okay, so en México el tratamiento de reemplazo hormonal en personas transgénero o no binarias menores de 18 años es legal en toda la República, mientras que tengamos el consentimiento informado de ambos padres o tutores. Si en algún momento el padre o madre tuvieran alguna situación de discordancia, se tendría que tener, por así decirlo, la patria potestad, o sea, la mayoría de toma de decisiones. Si de todos modos no se existe un acuerdo, se puede llegar a un amparo de acuerdo al mayor beneficio que pudiera tener el adolescente o la adolescente o la persona no binaria. Sí, a nivel legal para cambio de nombre en menores de 18 años también, sí, en toda la República ya, desde el 2023 está aceptado que sea el cambio si tiene autorización de ambos padres o tutores, pero hay varios estados en los cuales, a pesar de que la Corte lo mencionó como algo para toda la República, tienen que realizar un amparo. Es un trámite legal. Pero ahorita nos platico un poco, Sabine, sobre estas cuestiones en Europa. Creo que si hubiera ahí que no terminé de contestar la pregunta, me hacen saber, por favor. So, Sabine, back there, I believe there's different points of view depending of the of the country, no? It's not the same in Netherlands that, I don't know, in Germany and Spain, okay, about starting hormone treatment in adolescents.
Yes, I think all the countries have their own laws. I can say a little bit about the Netherlands. So in Netherlands, the treatment is not so it's like other legal treatments or other medical treatments. Sorry, there is no specific law about medical treatment for transgender adolescents, but the law does say that below 12, both parents decide or legal legal guardians about the treatment, and then between 12 and 16 the adolescents and parents together decide, and only from age 16 the adolescent can decide by themselves. So for younger adolescents, the parents have to support the treatment. If they don't want it, we cannot provide the treatment.
After
and
16,
then for the
is it?
So then it's not legally required to have permission from the parents, but of course, I think there's a lot of other reasons why support from parents is generally very important to adolescents, because often they live at home. So I think it's very difficult if the parents really do not support their treatment at all. It's very difficult for adolescents to then go ahead anyway. But from a purely legal point of view, from 16, they can decide by themselves.
Okay, thank you. And
there's
I'm
other
just
change,
going
like there's also some legal issues like with name change, but I don't know if people want to, or change in the passport, for example. So in the Netherlands, there was a change in the law. It used to be necessary to have a gonadectomy before you could change your passport until 2014, and that was changed because looking back, people said this is really terrible that you have to have a gonadectomy before you can change your passport. So this is no longer necessary. From age 16, you can change your passport with, you still need a report from a psychologist that you have thought this through, and before age 16, it's more difficult. It's a more complex legal procedure if you want to change your passport.
Okay, so here in Mexico also it's likewise. We don't need a surgical transition for changing your legal name or passport or everything. It depends in the state that you are, if you have to have some other type of legal requirements. but also it's having the authorization of both parents or tutors. There are some other questions, Sabine. So Dr. Juan Ramon is asking you if you have any experience using ciproterone and as an estradiol blocker in transgender adolescents back there.
Yeah, so in Amsterdam, we didn't use it for adolescents. Like traditionally, it was always a GnRH analog, but it used to be the treatment to suppress testosterone in adults. Until quite recently, it's now the adult endocrinologists have now also changed to GnRH analogs, mainly because of the worries about the side effects of cyproterone acetate, particularly the FDA warning for risk of meningioma with prolonged use in higher doses. I know it is still used, so I guess in Netherlands it's reimbursed the GnRH analog, so then it's a bit easier. But in other countries it's not reimbursed, and of course the GnRH analogs are very expensive. So I know some other countries do use cyproterone acetate in adolescents as well. For example, a clinic in Belgium, and they've also published a paper on the experience. So I can post it in the chat maybe, so people can have a look. Because it is also used effectively to suppress male puberty, and actually also results in a bit of breast development. So that's well, some adolescents may be happy with that. And there's also a paper on effects on body composition and bone. I'm also posting it in the chat. But I think if people do use this, it's good to be aware and to counsel about the potential side effects and to use a low dose, because in the past quite a high dose was used, and it's now been shown that that is really not necessary. It is also mentioned in the SPE EndoERN paper as an option, but just be aware of the potential side effects.
Exactly. So Juan Ramon says, thank you so much. Yeah. So here in Mexico, we also have some experience with cyproterone and adolescents, because here we don't have the opportunity for all our transgender persons to have the opportunity of having GnRH analogs. And up until now, at least in CATI, that is our clinic, we don't have any type of transaminosemia or meningioma, and we already have like 10 years of follow-up. So yeah, it's the thing about being in a country that we don't still have all these treatments from our government. But yeah, thank you for sharing those publications. There's also some other comments from Dr. Mario Guillermo. So he's from Veracruz, that is a state here in Mexico. So yeah, they're telling us that there's been difficulties having this authorization for legal judges to have this mechanism, so we can start gender therapy. So I will answer that in Spanish a little bit. Doctor Mario, sí, lamentablemente puede haber retraso en estos amparos, pero si no, en un momento también quien nos ha llevado a nosotros los casos para amparos nos ha ayudado bastante en toda la República. ¿Para qué? Para que podamos realizar estos tipos de tratamiento, inclusive si son mayores de 16 años, si podamos tener por lo menos esa garantía de empezar bloqueadores. En un momento les comparto el teléfono del licenciado Quetzalcoatl, que es quien nos ha apoyado en cuestiones legales, tanto en personas que viven aquí o que tienen doble nacionalidad. So also there's another question. How about cyproterone as a testosterone blocker?
Yeah, I think that was just a correction of the comment above, because it was asked as an estradiol blocker. So I think that person just wanted to correct. So we discussed the question.
Yeah. Okay. So I have a question, Sabine. Does all adolescents pass to your fertility council. So do you have like a follow-up? Okay, so they go like to mental health, afterwards laboratory, endocrinology, and even though if they are not soliciting fertility, do they go through a fertility clinic just to have the information and not having like the absence of information?
Yeah, so we have the fertility specialist in the transgender clinic. So we have one clinic where all the specialists work. So we work like in the room next to me, there'll be a mental health professional or gynecologist or a
Oh,
surgeon so that's, I think, really, I think that's really great, but of course it may not be possible everywhere. So we offer it to everyone. So the sort of standard is that they will have a conversation with a fertility specialist, but if people really don't want it, it's not like they have to have it, but we offer it as the standard of care. I think sometimes the adolescents do find it quite difficult to have this conversation and hear all the details. So sometimes I think, especially if they're younger, then it's more the parents that would like to have the information, because of course they are also partly responsible for the decision, at least in like the legal way. So they also like to know what is going on, and we are evaluating. We did do one paper. I can also put it in the chat if you like. That we evaluated what did they think about the fertility counseling, and how did the children and the children and their parents evaluated. So we do still offer it, but we are thinking should we change it a little bit, especially for the. I think for the transgender, transmasculine adolescents, a really low percentage undergoes the oocyte preservation because it's quite invasive. And with everything we know right now, they don't have to do it so early on, so they can postpone their choice. So then, of course, it's the question: do you want to do the extensive counseling that early? I think it should definitely be available if people want the information. We should provide it, but maybe it's not. Maybe some people don't need to see the fertility specialist if they don't have particular questions. And that's of course if the mental health professional or the endocrinologist has enough information and can inform them about the basic information, so that they do know what the treatment will do and what their options are.
and well, I also have another question. So how for DEXA scans, how often do you measure them? If you're, I believe, well, what we are doing also in our adolescence is having a first DEXA scan, and afterwards evaluating how they are doing. But if they're not so under the set score, how often do you follow up?
So yeah, we do one at the start of the puberty suppression, and then at the start of hormone treatment. And if it's really long, like if they would start very young and it would be a really long period, we would repeat it after 2 years. And then again at the start of hormone treatment, and then we do it again after about 2 years, and then in early adulthood to see what their sort of peak bone mass is. I think it depends a little bit if they are on a puberty suppression for a really brief period and then they start testosterone, for example. I would not be so worried because
Yeah,
it doesn't look like
exactly.
testosterone has a negative impact on the bone. But I think particularly for the trans feminine adolescents, as I showed you, even without treatment, we see
Yeah,
quite low bone mineral density, and especially if they are on puberty suppression for a long time as well, they sometimes go quite low. Yeah, the question is, of course, what difference does it really make to your treatment? Do you do anything
exactly.
differently if it's very low? So I think we do the dose of the estrogen may have some influence on this. We also did a paper that showed that if you increase it more quickly, the bone mineral density does seem to go up a bit quicker as well. So you could adjust your dose. If also taking other things into consideration, of course, if the people are happy with it and if they have side effects, but that could be a reason to adapt your treatment maybe a little bit. And of course, all the lifestyle things, but we should advise them anyway, I think,
Exactly.
independent of the
Yeah.
of the Z score.
Yeah, at least what we have been seeing is that unfortunately we have really low vitamin D levels in all our transgender adolescents, lower in our female trans, but also, as you say, no, less physical activity and everything that it's lower body mass index. So there's a lot of things that we are certain of in the follow-up, at least in our mental health evaluation, about also um, uh, um, like bulimia or anorexia. We also have been seeing a lot of these cases, and it's not being like discussed a lot.
No, I think that's really important to also see if there's something, something else going on, which would obviously also, be important for their general health and for their bone health, but also their whole development. Yeah.
So I will ask if there are some other questions. ¿Hay alguna otra pregunta para no interrumpir sus actividades, dado que tenemos solamente 4 minutos más? So I think that has been all the questions. Well, I have a lot of questions, but everybody and also you have all your schedule, and it has been lovely hearing you one more time, and all the messages and the chat is that it was also wonderful for them and such an enriching lecture. So we would be fortunate to hear you one more time whenever, if it is possible. So really, really so much appreciation for giving us some of your time on Saturday.
Oh, thank you, and for all attending on the Saturday morning. I think that's really wonderful, and I wish you all a really good day, and hopefully see. It would be lovely to see some of you again in the future.
Yeah, so they're asking if it could be possible to have your email if they are also having some other questions.
Yeah, for sure.
Thank you. So can I just send them your email, or can you just text it on the chat?
Yeah, that's it.
Thank you. Thank you, Sabine. So, thanks a lot, Sabine. And muchas gracias a todos por su tiempo y por querer tener un mayor aprendizaje para nuestros pacientes, un mejor tratamiento. Muchas gracias. So, thank you, Sabine. Have a good one.
Bye. Have a nice day.
Ciao.
Ciao.
Ciao, Sabine. Thank you.
Pues muchas gracias, Elmita, estuvo súper interesante. Ya está, te pidieron que hablemos luego en la sesión del grupo de aspectos legales. Dicen que también.
Sí, el licenciado Sandoval, Quetzalcóatl, sí, o sea, de hecho, muchas veces nada más cuando da asesoría a veces pide 200 pesos. Es una gran persona y sí es súper movido. Nos ha ayudado también en transiciones de personas que tienen doble nacionalidad. ¿Para qué? Para que no tengan mayor problema. Entonces sí, claro que sí se puede abordar como los temas legales.
Ah, excelente. Pues luego platicamos para armar una sesión. Tú que conoces
Sí, sí.
perfectamente, eres experta en el tema.
Sí. Pues muchas gracias a
Muchas
todos.
gracias.
Hasta luego.
Hasta luego.
Bye.
Bye.